Good afternoon, everyone, and welcome to the Independent Sage briefing, the first of our bi-weekly news shows on a Friday afternoon. So before we get going, first things first, and a real sincere thank you to everyone who contributed to our crowdfunder the other week and made it such a huge success. We had over 500 supporters who contributed and made this happen, and we reached our target within 3 days of launching the event, which was astonishing to us, especially at times like this. It's given us the fuel and resource we need to run briefings for another year. And that's just amazing. So we feel very, very grateful. We feel humbled, and especially humbled by all the warm and supportive comments that you left us on the website. They were really incredible to read. Thank you so much. As you know, all the scientists here on the panel, we give our time for free. And we greatly value the opportunity and the role that we play as Independent Sage to disseminate what we hope is reliable information, to push for changes in policy, and to make other changes wherever we can, and to try and get the truth out to people. The funds that we collected, we assure you, will purely go into running the media side of things. So the citizens, our partners here, you may see these screens before you, but there are other people behind the scenes making all of this happen. They're putting these briefings up as a major part of that, but it's not the only job they do for us, and we have a huge amount of thanks and gratitude for them. So again, our sincere thank you to everyone who's continued to support us in all sorts of ways, not just through money. So now on to business. And today we're going to have a really interesting session on the COVID pledge. And for those of you who don't remember,
oh, you've muted Steve.
Yeah, that was odd. It said the host muted me. I do apologise about that. Today we're going to have a session on the COVID pledge. It's a campaign we launched last year at Independent Sage, wanted to give employers and employees, importantly, a framework to create safer work spaces. The idea of living with this virus is that we make it safe to do so. But before we hear more about that, I'd like to invite Dr Kit Yates to give us a presentation on the latest numbers around and about the place. Over to you, Kit.
Great. Thanks, Steve. So yeah, latest numbers, I've got the date wrong, unfortunately, on that. It's 2 weeks hence. That was our last one. Apologies. It is the 17th today. So where are we on the 17th? Cases are rising, probably, but more slowly than we've seen in previous waves, or where we've been in the middle of previous waves, perhaps. Hospitalizations are also increasing, but again, quite slowly at the moment. So indications that we might be coming to the end of this recent uptick that's lasted for the last 2.5 weeks or so. And then deaths are still coming down from the last wave that we had. So what I'm going to cover today is prevalence, how many people are infected, hospitalizations, what's happening in hospitals, deaths, how many people are dying as a result of COVID, and also, because we're looking at the pledge and that has a big impact on workplaces, we're going to talk a little bit about workforce absence to set that session up. So firstly, as is traditional, we'll look at prevalence. So these are the current rates of COVID across the 4 home nations. So roughly similar, around 2% in England and Scotland, 1.5% in Wales, and it's actually lowest in Northern Ireland, although there's traditionally the most uncertainty associated with Northern Ireland because their population is slightly smaller and the sample population slightly smaller. So a bit more uncertainty there, but yeah, same sort of picture. But as you can see from the right-hand side of this panel, as you can see from the right-hand side of the panel over here, we are seeing upticks in all nations, apart from Northern Ireland, again, where it's less certain, but we're seeing upticks in the number of people who have got COVID at the moment. So in England, it's around 1 in 55. Similar in Scotland, so that was just under 2% that we saw. Wales is 1 in 65, so around 1.5%, and then Northern Ireland is 1 in 80, and you can see the black line there's just dipped, but the other 3 are currently going upwards. It's important to say that the ONS data that I just showed you is lagged by about 2 weeks, maybe. So that data was for the week ending the 7th of February, which includes data from the start of February up to 7th of February there. So samples will have been taken across that time period of that week. So it's a bit out of date already. It's around 2 weeks out of date. And so we often look at the Zoe symptom tracker, which we know has perhaps some flaws in terms of its absolute numbers, but we think is doing the right thing in terms of catching the turning points for these waves. And at the moment, it looks like prevalence is continuing to increasing, but it's important to say that it's going up more slowly. And also that if you look at incidence, which is rather than how many people are infected, that's the prevalence. If you look at incidence, which is the number of new cases per day, that's one measure of it, then actually for the last 2 or 3 days, that's been coming down on the Zoe Symptom Tracker Act. So it hints that we may have peaked, although we won't see that in the ONS data, which is our gold standard, for perhaps another couple of weeks. We might expect to see it still going up. Again, this is from the ONS, looking across different regions of England. You can see that there have been rises across all regions of England. So grey bars are previous data, and orange is the most recent. And you can see there's been an increase in every region in England. And similarly, when we look at age groups, there's been an increase across all age groups, with the possible exception of these 25 to 34 and age 2 to year 6 students, where it looks like there's an increase, but of course there's uncertainty in those data, so it may be level around there. So overall, again, this is the picture from a couple of weeks ago, but things in cases have been increasing. In terms of hospitalizations, again, these data are lagged a little bit, maybe by 10 days or so. We have been seeing increases, but again, they've been slower than we've seen in the middle of previous upticks. So potentially hinting that we are coming towards the end of this uptick with a lower height, if you like. But also remember that we didn't get as low down previously as we have done before. So we're leveling out somewhere in the middle of this area. And again, just breaking this down by age group, you can see that the most affected groups are the older people. These are people going into hospital, and you can see that over 65 daily admissions are significantly higher than under 65 daily admissions, despite the fact that under 65s make up a larger proportion of the population. So just re-emphasising that COVID does disproportionately affect the elderly, but also to emphasise that cases are going up still in both of these groups, or the hospitalisations are going up in both of these groups at the moment. And then this is in terms of occupied beds. So this is sort of equivalent to the prevalence estimate. Again, we can see it continuing to go up, and we'd expect it to continue to go up even after admissions decreases for a little while, but then hopefully to come down. But at the moment, we're not quite seeing the signs of a decline in hospital beds occupied by people with COVID. And again, these are the hospital admission rates by region, and you can see that they're all increasing at the moment. Still, the orange bars are the highest, except possibly for the east of England. Some strange anomalies with the east of England. They had a very big increase last week. Something odd going on with their data, perhaps, and so they've seen maybe a correction to that this week. But certainly, that was an anomalously high increase we saw last week. Flu, again, I just want to, I don't want to go on about flu too much, but we looked like we leveled out a little bit last week, and it's come down again. So this flu wave is almost done with. Yeah, that's all I really want to say about flu, that it's come down again this week. And then looking at deaths, this is deaths with COVID on the death certificate. And again, we can see that deaths have been falling for a couple of weeks now. And that's a result of the falls that we saw in the previous wave. And of course, deaths being lagged compared to cases by 3 or 4 weeks. And so we won't expect to see this uptick for another week or so, but it will eventually start to rise again. And I guess I wanted to emphasize that, again, we're still around this level of 100 deaths a day at the moment, which adds up over the course of a year, of course. So the last thing that I want to talk about is workforce absence, because we're doing this session today on the pledge and trying to make workplaces safer. So this was a headline from the Daily Telegraph a couple of days ago, which was outlining a potential government policy which was designed to suggest that GPs should be signing fewer people off work with what are now called fit notes rather than sick notes, but signing people off work less and getting them back into the workforce. And I guess there is a number of reasons why this might not be the most sensible policy. It is, not going to be a particularly effective worker if you're not feeling very well, not up to the job. Also might set back your recovery. And if you're sick with, with an infectious disease like COVID, and you're currently infectious, then it's not a good idea to go and bring that into the workplace. So there's lots of arguments against this, but I just wanted to back that up with some data, I suppose. So this is UK sickness absence between 2000 and 2021. We don't have the data for 2022 yet. That doesn't come out till April. You can see that actually there's been a steady decline in the number of workplace absence, or the amount of workplace absence. This is actually measured in hours of workplace absence. Even in 2020, actually, we saw a decrease, potentially as a result of the fact that we were working at home more, and furlough was happening, and various other aspects meant that actually people were better able to work, who hadn't been able to work previously, were better able to work from home. But then in 2021, we saw this big uptick in the amount of workplace absence, and this is the highest level since 2009, all the way back over here. So it's been a really big jump in 2021, and I guess we're expecting a continued rise in 2022 when that data comes out. Looking at this broken down by age, you can see that actually all age groups have seen an increase. Again, this is the same colour scheme as before. Orange is the most recent, grey is the furthest away, again, lightest grey is the furthest away. And you can see that over the last 4 years, we've seen an increase in all age groups. And as you might expect, workplace absence or sickness absence gets higher the older you are. When you look at the reasons for people being off sick, this is in 2021. COVID is actually the first reason, which is just a single identified reason. It's slightly lower than other, which is obviously a combination of multiple different things, but COVID-19 was the number one reason for people being off work, or the leading cause of sickness absence in the UK in 2021. And there are other conditions, and I'm not saying that we shouldn't be doing things about these other conditions, but certainly COVID has played a big role in the amount of sickness absence that we've seen. If you break it down by industry, so where these people are working, it's sort of unsurprising to see that human health and social work activities are amongst the leading rates, similar with transport and storage. We know that health care and social work were hugely impacted by COVID, as was transport, as was education to a large degree as well. So it's sort of unsurprising to see these increases, although with education, remember, of course, in 2021, schools were shut for a large amount of time. So that's perhaps why it's not higher up this table at that point, but we might see that change when we get the 2022 data coming in. Again, this is looking at people who are living with long COVID now. So this is just specifically COVID rather than general sickness that we've been looking at before, breaking down the people who are self-reporting long COVID for any duration by the job sector they work in. Again, it's sort of unsurprising to see social care, healthcare, teaching and education, transport, retail, all these sectors which we knew were disproportionately affected by COVID because they had face-to-face roles, which meant you had lots of contact. It was difficult to or impossible to work from home in these sectors. It's sort of unsurprising to see that COVID is long COVID is highly prevalent in these areas. And then this is the same figures, only breaking it down by how people responded to the question, how impacted were you? So red is severely limited in your activity, and orange is limited a little bit. And you can see again, social care up here at the top, healthcare, teaching, education. And I suppose the question raised by that article that I showed the headline of before is it going to be helpful if someone is severely limited in their activity, or even partly limited? Is it going to be helpful if the doctor refuses to sign a fit note and means that person has to go back to work, or ends up just quitting that job completely? And I suggest the answer is probably no. Final point on this is one thing that, there's lots of things we could be doing to prevent COVID in particular, in terms of ventilation in workplaces, filtration. We've talked about wearing masks, all these sorts of things. But one thing that we could also be doing is improving healthcare so that people, when they are unwell, don't feel obliged to go into work, or when they're unwell with anything, not just COVID, but they don't rush themselves back to work before they're ready because there's pressure on them because they're only getting paid 20% sick pay. So, these are other comparable nations in the European Union, and it's sort of embarrassing, isn't it, how low down we are on that list. So that's where I'll finish. I'll just summarise to say prevalence is still increasing, although incidence may have turned a corner. We may be coming down in terms of the number of new cases per day, according to the Zoe app, but we'll probably have to wait for the ONS to confirm that or for a little bit more time to pass. Hospitalizations are still rising, but again, more slowly than they have been in the past. Deaths are falling, but as we know, that's a result of the falls we've seen previously. They're still at relatively high levels, and we can expect them to increase again soon. And then in terms of the workforce, we're seeing increasing numbers of people out of the workforce through to ill health, and COVID is certainly contributing substantially to that. And there's certainly more things we could be doing about that. So on that note, I'll pass back to Steve, who I'm sure will introduce the rest of the session. Thanks.
Thank you ever so much, Kit, for a really brilliant summary, which was also rather worrying. It's very stark, isn't it, how the bottom line for COVID is so much higher than that for influenza. It goes to show that the pool of susceptible people is continually being replenished, and we really do need a long-term solution for this. And obviously signing people off sick and stopping that happening is a very short-term response and rather delusional, in my opinion. What we really need is long-term solutions for this. And on that point, our session today is going to be on our COVID pledge. So I'd like to hand over to our very own Professor Stephen Reicher, who, along with Janet Newsham, who's the chair of the Hazards Campaign, is going to run this session, and I'll hand it over to them to introduce our guests and kick this session off. Over to you, Steve.
Hi, and thanks, Kit, for those really revealing figures, many of which I hadn't seen before and which are really helpful, I think, in terms of setting up this session. Because in Independent Sage, we've always said there are two consequences of COVID denialism, the pretense that it's all over and we don't have to do anything. The first, of course, is to ignore the ongoing burden of COVID infection, the ongoing burden on the NHS, the ongoing burden on the economy, in particular, the ongoing burden on clinically vulnerable people and their families and their carers, who amount probably, if you put it all together, to not far off 10 million people. And they and their reality and their lives are still considerably constrained. For them, there is a continuous lockdown as long as public spaces, because remember, workplaces are also public spaces. They're the restaurants in which we eat, the shops in which we shop, and so on. That, as I say, if those are unsafe, then they are unable to participate socially. And the second consequence, I think, is equally important, that we very quickly forget things that we spoke about continuously a year or two back. We talked about build back better. We talked about learn. And one of the things we've learned, of course, is that clean air and safe workplaces are as important as clean water was, and a campaign to get us clean air and safe workplaces and safe public spaces, it's every bit as important as building the sewers was in the 19th century and building clean water was in the 20th century. And if there are, I think, two huge scandals in this country, and scandals which we really need to do something about, it is that despite the fact that we have laws which demand health and safety at work, they are not observed in practice, partly because the Health and Safety Inspectorate has been absolutely decimated. And so people have to go to work in unhealthy environments. And the second, and here the figures from Kit speak eloquently, we live in a country where you can't afford to be sick. You can't afford to stay home if you're unwell. And as I say, that's an absolute scandal that we should be ashamed about. And the pledge is designed to do something about both by demanding that the government does something, but also by demanding that every enterprise does something, that it happens from a grassroots level, from the bottom up, as well as the top down. And so in today's session, first of all, Janet Newsham, who's already been introduced, who is the co-chair of the COVID Pledge Campaign Committee and also from the Hazards Campaign. Janet is going to outline the pledge and say something about the week of action that we're planning to hold. And then we have two guests who we're going to interview. First of all, one of the guests will be known to many of you and is a good friend of Independent Sage. It's Lara Wong from the Clinically Vulnerable Families. And we're going to discuss together the issue of what the reality is like for vulnerable people and what needs to be done and how the pledge can help. And then secondly, we have James Robinson, who is branch secretary of Knowsley Unison, who has managed to get Knowsley Council to accept the pledge and enact the pledge, and it's a good and inspirational example of what can be done. So I'll hand over immediately to Janet to start us off.
Thank you very much. So COVID mitigation is still very important, especially when we consider that millions of people have developed and are developing long COVID, and the continuing deaths from COVID, as we've heard before, or because of COVID. And although our government has made a political decision to pretend that COVID's disappeared, quite clearly it hasn't. The recent World Economic Forum annual meeting in Davos showed that what's necessary and what is possible to prevent the spread of infections. Those who attended benefited from daily testing, isolation, if they were positive, enhanced ventilation and other mitigations. And theirs was a meeting where cost of prevention and taking a precautionary approach wasn't an issue, unlike what is in place for the rest of us. We need employers to control the infection risks from COVID in our workplaces, including all those workplaces, health, social care, schools, transport, etc., and shops. The COVID Safety Pledge is a simple document. It's a means of achieving COVID-safe workplaces and public spaces. It commits employers to engage their workforce and to develop a plan of protection and to support workers to stay at home if they have COVID. COVID Safety Pledge signs will reassure workers, service users and customers that their health and safety is taken seriously. And the COVID, and as we say on our website, it makes good public sense to ensure that shops, restaurants and offices we use are properly ventilated and that no one is working while infected. But it also makes sound economic sense to give the public confidence that they can use these spaces safely. The COVID Pledge is an important initiative in driving mitigation and infection prevention. And there are some fantastic initiatives going on around the place. Michelle Wong on clean air classrooms supports the pledge because schools are a higher density and higher risk environment. And she and others have been campaigning for improved and good ventilation and outdoor classrooms. There are many places where vulnerable families are disproportionately impacted, and that is essential to reduce the chains of transmission and protect the community. And clean air is vital for healthy learning outcomes. And there's clear benefits of good air quality for children, but also for education and health professionals who work in these environments. There are other examples on social media that many of you will have seen, exemplary examples where individuals and organisations are driving the agenda on clean air, providing CO2 monitors and building Corsi Rosenthal boxes in schools. Individuals like Councillor Olive Patrick, Hilda Palmer, the Hazards and Glasgow Council trade unions who are working with their employer to provide CO2 monitors. The proposed public space ventilation, I'm sure that Lara will talk about, and we shouldn't forget the Independent Sage Scores and the Doors Initiative and the development of the CO2 maps, the Raven app to record CO2 levels, and other organisations globally in driving the debate on how to prevent infections. I don't know if you've seen the now famous Canadian apricot tree cafe that posts regularly on social media telling us about the CO2 levels. But please tell us some more examples, share those examples. Let's share and initiate good practice. In general terms, the aim of the COVID Pledge is to get as many employers as possible to sign up and display the pledge statement in their premises. Community organisations are a crucial component to helping create pressure from customers and consumers on businesses to help persuade them to adopt the pledge. And during the week beginning March the 20th, we're proposing that a week of action to agitate, educate and organise on COVID mitigation and invite employers to sign up to the pledge. We want to build local pledge coalitions. The idea is to have trade unions, public and local organisations campaigning together on the pledge. It's the 3rd anniversary of the start of the pandemic in the UK when we first went into lockdown, and we want people to do at least some of these actions to try and place COVID back on the agenda, contacting their employers and asking them to sign the pledge, contacting managers in public facilities that you use, shops, bars, restaurants, entertainment venues, public offices, etc., and ask them to sign up to the pledge. Consider a public event to support the pledge. And we invite you to use the ventilation audit that we've put on the website for you to go and audit your own workplaces. We already have a wide network of supporters amongst professional organisations, community organisations and trade unions, and we need to grow this network further. And we also need to get more employers to sign up to the pledge and implement its measures. As we all know, COVID hasn't gone away, despite what the government is pretending it has. And for all our health's sake, we need to control the infections and reduce the spread and its damage. And I'll hand back to Stephen. Thank you.
Right. So can I just say that when Janet talks about the website, we're talking about the COVID Pledge website, not the Indie Sage website. And in fact, it's been completely revamped in the last few weeks, and I think you'll be pleasantly surprised. It lists, of course, our sponsors, who are incredibly impressive. We have most of the major unions in the UK. We have the British Medical Association. We have a host of community organisations, vulnerable families, bereaved families, long COVID organisations. So superb list of sponsors, a growing list of companies, but now we've put on a whole series of really useful resources. So I think people will find it really helpful, and it gives good practical advice. In many ways, it echoes some of the work we do on these Friday sessions. But now I'm going to have a chat with Lara. So first of all, Lara, thanks very much for joining us again, for giving us your time. And let me start with a very simple question. For your members, for clinically vulnerable people, is COVID all over?
Well, we wish, but unfortunately, no. We are doing our best to take personal responsibility that we've been told to take. However, unfortunately, we know that public health needs to be involved, and we know that as individuals, protecting ourselves is not sufficient. And so, our clinical risk factors remain. We remain at high risk of the worst consequences from COVID, and that includes long COVID as well. So we can't necessarily move forward so easily. Vaccination obviously has improved our situation for many people, but there are still people who have had 6 vaccines and may have no immunity following that, or really low immunity following that. So they essentially remain at the start of the pandemic, but the rest of the world has moved on without them. And so it's incredibly difficult to live in these circumstances whilst facing sort of high risks. And everyone has their own risk, everyone has their own tolerance to risk. And so we have to sort of understand that there might be people who are, perhaps with life-limiting conditions. Maybe they want to sort of move on and try to forget their risks. And we fully understand that, everybody has to make their own decisions based on their own needs. But, by sort of making these decisions and, putting us in these situations, people do have very difficult decisions to make. And there is a correlation between people's high risks and their risk tolerance. So, what we want to do is we want to make things safer. We want to look at the environments. We want to look at sort of shops and things, because people are reporting the fact that, 3 years on, there are people who've still not entered a shop. They're still living in their own homes. They are struggling to go out. They are losing their friends. They're losing sort of communication with their families in some cases as well. So it's incredibly difficult. So, what we need to do is, as you say, the learning part of learning to live with COVID. We want to see, what is it that is now in place that's going to put people in a better position as we move forward. We need to see sort of more testing, people isolating based on those tests, not just saying this is a cold, because we know it's not.
And presumably, it's not only difficult for people who are vulnerable themselves, but if you're the child of a parent or a grandparent who is vulnerable, that must make life incredibly difficult for you and placing vast pressures and limit your activities in all sorts of ways.
Yes, it does. And that's the thing. And that's why our group is called Clinically Vulnerable Families, because there is an impact beyond that vulnerable person in the household. So just because somebody in a house is vulnerable, it doesn't mean that they can then isolate themselves and live in their own room for the rest of their life. They have to be part of their own household at the very least. And so, children in schools, partners in workplaces, and even themselves, if they are in workplaces, they need to have safe options. And there is advice for sort of severely immunosuppressed people, at least on the government website still, which refers to the fact that, you know, they should be working from home if they can. But if they can't, then they need to talk to their employer about that. And the employer might be able to offer them reasonable adjustments, but they aren't necessarily all considered disabled. So disability will qualify for a reasonable adjustment. But when we have people who are not disabled, then it's very difficult to have that conversation with an employer and to get that risk assessment in place that is then suitable to make their workplace safe for them.
So if you could create a wish list of the key things that you think would make a real difference, you know, if you were Prime Minister for a day, not that I wish it on you, you know, what would be the 3 things that you would implement?
I think we might need more than 3.
I'll limit you to 3 for now. You can have more later.
Yeah. So, I mean, I think firstly we want to see clean air. I mean, we really need to see clean air. It's vital for us going forwards. As you said, it's clean air, clean water. They should be considered in the same way. We consider fomite transfer of infections. We're not considering, you know, airborne infections, and that's not just limited to COVID. You know, we're looking at flu, RSV, strep A, all of these other infections that we keep talking about in the news, but we're doing nothing to combat. It's incredibly frustrating because if we had that learning in place, if we had clean air, if we had air filtration, you know, it would go much further than just protecting those individuals, which we should be doing anyway, but it's protecting the workforce from those absences that Kit mentioned earlier. You know, it's those long-term absences from long COVID as well. We need to be protecting people and considering those issues. So clean air, number 1. We'd like to see testing, really. It would be great. Saying that it's a cold is not very good for us. It is not a cold for us. It really is not. And we cannot continue sort of down this pathway. So we want to see testing. Ideally, you know, it'd be great if employers could support that, because actually they're protecting their own workforce. You know, if it was available in your workplace, if you've got a cold, well, maybe I can just test and see, is it COVID? That would be fantastic. And obviously, sort of, you know, that would then run on into isolation. So I'm tying 2 together, sorry. But obviously that would be appropriate isolation. And we would like to see workers supported in wearing masks, or people just generally in the public supported wearing masks. If someone is wearing a mask right now, usually they have a very good reason, and usually they are vulnerable themselves, or vulnerable in their household, or they are concerned about their own risks for one reason or the other. And we should be supporting those people to make that choice.
And of course, one of the best ways we can support them is by wearing masks ourselves. I'm aware of time. There are so many things that I think we could discuss. I just wonder whether we can finish on a positive note. Can you give us any inspirational examples of good practice which have made a difference, either at a local level, a small level, or at a national level? Anything to make us feel a little bit more positive?
I mean, certainly internationally, I can say that there's some good practice that we've seen. If you look at sort of places like Japan, talking about CO2 monitoring, they are reporting in various places CO2 levels. As we mentioned earlier, the Raven app, people can share that information. If they have their own CO2 monitors, they can upload information about the places that they are visiting, times of day, occupancy. That kind of information is also very useful to people to understand the risks, and it gives them an idea of what the ventilation is like in those places, and so then they can see, you know, is this a risk that I want to take? Is this a risk I can take? People can make judgments. The less information we have, the harder it becomes. So the less people are testing, the less the ONS is reporting, the further back the lag, the less information we have, and it's very difficult for us to move on. So yes, we want to see those things, and it'd be brilliant to see more people using the Raven app in the UK.
Okay. Well, thanks very much. We could go on for a long time, but we have limited time. I think what you've said exemplifies something that probably Susan Mickey would say if she was with us today, which is it's all very well talking about personal responsibility, but people can't exercise that responsibility unless you give them information and unless you give them the resources so they can keep safe, so they need to know what areas are safe. They need to know that there are shops and workplaces which have safe practices. They need to be given the resources so they can test and wear masks and so on. So really important messages. But now I'm going to hand back to Janet, who is going to be discussing with James Robinson from Knowsley Unison to give us an example of what can be done and possibly what all of us could make happen. So back to you.
Thank you. And thanks for joining us, James. It's really good to see you. So James is the Unison Branch Secretary at Knowsley Council, and your employer accepted the COVID pledge last October. What sort of workplaces does your employer cover?
Yeah, so as local government branch secretary, we represent all of the schools across Knowsley. So we've got 61 schools. We then have all of the council buildings, and then we've got a couple of arm's length companies that run our leisure services that would also be covered by the pledge.
So that's a really good wide-ranging number of employers. Why did you take the action to get your employer to sign up to the pledge?
Yeah, well, if you recall back it was around the summer of 2022, there was a number of employers and certainly a number of councils who were starting to look closely at the temporary sickness policies that they had in place. We were aware of this. We were aware that Knowsley were looking at other authorities in our Liverpool City region. We were aware that some councils have started to treat COVID absence in line with any other sickness absence. So that led us to look at a number of ways we could combat that. One of them was being aware of this COVID safety pledge. We were aware of that by a couple of formats, one of which was the hazards campaign yourself, Janet, and also we were sent information from Unison's national office, which made reference to it as well.
Thank you. And what do you think's been achieved by, is it just the sickness absence that you've managed to achieve, but what other things have you achieved?
Yeah, well, just to come back to that, using the pledge, what we did was, when we raised this in our normal joint consultative committees that we had, we weren't really getting much ground with this because those people who sit on that forum were just focused very much on getting sickness absence down, and they felt it was long time before they started treating COVID sickness like any other sickness, and was making reference to various other employers. But what we did was we used the Joint Health and Safety Committee at the same time to table this as an agenda item. And we got the Joint Health and Safety Committee to put this forward. And that's how the senior management within the council were then able to be convinced to sign up to this pledge. So, as I say, come the October, Knowsley Council signed up to it, and that immediately meant, and I remember the phone call from HR when we got it, and they rang us and they were like, we've got to rewrite every policy again as a result of this. And like, quite right as well, and it just put a halt to what was a risk to us in the policies changing, and still to this day, we still are certainly for the infectious period of COVID, that will not be counted towards sickness absence trigger points. People will get full sickness absence entitlement, even though they haven't built that up. So that'll be from day one for certainly that first period of absence. To come back to your question, what that also helped with was to keep the risk assessments that we had in place. So we had, like everyone else had, we had hundreds of COVID risk assessments in place across all our different workplaces and across all of our schools. We've been able to keep almost all of those mitigations that we put in place in those risk assessments, they remain until they consult with us to change them. So, you know, things like ventilation, you've mentioned CO2 monitors today, they're all still in the risk assessments. So they're all still being, you know, employed across the workplaces. And I don't think that we would have had an easier job in keeping them in place if we hadn't got the council to commit and sign up to this pledge back in October.
I think that's a fantastic achievement that you've got in place there, and you know, managing to keep that those mitigations in place. So, what would you say to other employers in terms of signing up to the pledge? What would you say to them? You know, why should they sign up to the pledge?
Well, if we can just focus on local councils at first, where we got this in, I know that councils at the moment are struggling to retain staff, they're struggling to recruit staff, pay being a major issue, as I'm sure you are all aware of it. But in that field where they are competing, local authorities, for talent, then this is something that they can show to say, look, you know, come work for us. We're a COVID-safe workplace. We're signed up to the pledge. It's advertised. You know, it's in our workspaces. It's just something else that they can help in terms of that recruitment and retention, which I know local authorities across the country are facing at this moment in time. I would also say as well, because a lot of this comes back to, well, what does the local elected councillors think about this? Because everything has to be run past them eventually. But why wouldn't local authorities want their council to be COVID safe in terms of access to their residents? You know, if residents are coming in to Knowsley Council, for example, they know they're coming into a COVID secure place with COVID risk assessment, ventilation, etc. So that helps when you're speaking to local councillors about and gaining their support for introducing this. Thanks very much, James. I think that's really interesting, like, you know, and inspiring, really, what you've managed to achieve there. And, you know, when you think back to what Lara was saying, you know, it's heartbreaking that people have been put in that position where they're not being supported to, you know, back in the workplaces. So I think it's a brilliant achievement what you've got there. Thank you very much. Thanks, Janet. Cheers. Thank you.
Okay, well, just to wrap up very quickly, I mean, first of all, thank you to Lara and to James. I think we ought to probably have you on every week. Lara, in response to those who say it's all over, and then when we get depressed, then to have James on to make the point that actually people can make a difference, a real difference. So thanks immensely for your work, James. Thanks to everyone. Look at the COVID Pledge website, look for the activities in the week of action, and let's spread what's been started in, you know, beacon sites like Knowsley Council, and I think we can get a long way if we do. So thank you everybody for taking part in the session today.
Brilliant. Thank you so much, Steve, and also to Janet, Lara, and to James for a really, really interesting session and a really positive session as well. Hopefully moving forward, we can all do our bit to move this forward. There is a link to the COVID Pledge website if you want to find it on the Independence Age website if you can't find it, but it comes up first on Google, so please do look that up. Now I'll move things on very quickly to our public questions, because they're one of the most important things that we like to do on Independence Age, and delighted to say that our first question is going to be delivered in person by Rebecca Davies. So Rebecca, if you'd like to unmute and ask your question.
Hi everyone, and hello from Belfast. I am a mum of 2 preschool kids, and we've just come through our first dose with COVID, our first of since the pandemic began. I would really like to hear the panel's thoughts about the possible link between COVID and immune dysregulation in both adults and kids. I'm really struggling, and I imagine the panel and our watchers are too, maybe as well, with the apparent disconnect between this possible risk and the current policy of choosing not to reduce transmission and limiting vaccination for under 50s and children. And as we've been discussing, no significant focus on cleaner indoor air. So can I ask you what you think? Thank you.
Of course, Rebecca, really important topic. I imagine one or two of us may have something to say on this, perhaps Sheena or Danny?
Yeah, so I think it's really important that we try and reduce the impacts of infection and the likelihood of being infected for our children, because particularly the very young children are going to be this generation that are not going to receive a vaccine at all moving forward. And looking at some of the hospitalization data that we've been seeing in our COVID briefings, we can see that children, very young children, are about as vulnerable as the over 70s group. So it's shocking that they are being left exposed in this way. And of course, people like Lara have shared with us the experience of people with long COVID, including children. We know children get long COVID. So this is a significant condition. In terms of long-term impacts around immune deficiency, currently the evidence is not really there to say that it has a broad effect on your immune response and makes you more vulnerable to other infections. But that doesn't mean that we shouldn't be trying to mitigate against the very worst that COVID can do.
Great, thanks, Sheena. Danny, have you got anything to add?
Yeah, not much to add to that. So I think every time that Sheena or I say anything at all about effects of COVID on the immune system, we offend some people, because people are very passionate and polarized about COVID, aren't they? And some people out there are saying, oh, it's just like HIV, it destroys your immune system. And other people are saying it's just like a cold, it does nothing to you at all. And, the answer is probably a straight line somewhere down the middle, that because we've looked an awful lot, we've described a lot of quite nuanced effects on the immune system. We don't know yet, never really seen yet, that playing out in terms of any big new vulnerabilities or susceptibilities to other infections. There's a big new study out of the United States last week saying that, sort of slightly paradoxically, some vaccine responses are actually enhanced in people who've had their immune system kind of reprogrammed by COVID. So, without getting too hoity-toity and fancy about it, just a way of saying that it has messed with our immune system, but in quite nuanced and subtle ways.
Brilliant, really important point, Danny. I think nuance is the key. Oh, Aris, got something to add?
Just to add a quick point. I mean, all the stuff that Danny and Sheena said, I agree with. But in terms of short-term follow-up, what would be a lot less surprising, though, is an episode of COVID, as with an episode of any viral infection, rendering someone more vulnerable to a follow-on secondary infection over the coming weeks and months. That is certainly something that is possible, and for individuals who are vulnerable and generally concerned about infection, that's certainly something to be looking out for.
Yes, I completely agree with that, Aris. Anthony?
Yeah, Rebecca, just to say, I mean, we know that, children generally tolerate this virus better than, much older people, but still a very significant number in the thousands, actually tens of thousands in America and Europe combined, get a multi-inflammatory syndrome, which is nasty and can put up to half of them into intensive care. And a very small number, but not trivial, actually die from this disease. Now, it's just to say that Ireland today have announced that they are going to offer vaccination to all children above the age of 6 months. And the USA have done the same. I'm not quite sure what's happening across Europe, but I wouldn't be surprised if they follow. So the UK is very much an outlier in terms of protecting children with a vaccine.
Yes, that's a really important point, Anthony. And the US, of course, going from 6 months as well. Okay, thank you so much, Rebecca. That's a really important question. I'm going to move on just to try and squeeze some more questions in. Thanks for giving our question in person today. Okay, so the next person I'd like to invite is John Hebden. Are you here, John? There we are. Brilliant.
Yeah.
John, would you like to unmute and ask your question, please?
Yeah. So my question is about the publicity around the primary symptoms of COVID. And I note there's a huge divergence between what's on the NHS website and what, for example, the Zoe symptom tracker says are the main symptoms. So the last time I looked, the Zoe had the top 5 as sore throat, runny nose, blocked nose, sneezing and headache. In contrast to that, the NHS top 5 was high temperature, new continuous cough, change in taste and smell, shortness of breath, and fatigue, which seemed to me to still be the top 5 symptoms that date back 3 years to the Wuhan strain. But the information that, for example, the people who provide my primary health care go with, so when I phone up the GP, I get the list that is on the NHS website. So my question really is, does that matter? And if it does matter, what can be done to bring the information more up to date?
That's a really important question, John. Christina.
Yeah, so I think it does matter, and it was only last spring that they actually updated it from the 3 symptoms. I think what they've done is they've prioritized symptoms that are more specific to COVID, like loss of taste or smell, which is really unlikely to be anything else. But as you say, the most common symptoms are just cold-like or flu-like symptoms. I think it matters because people assume it's not COVID. And so, for instance, at the moment, flu and RSV are really low, rhinovirus is falling, COVID is increasing. So if you have cold or flu symptoms, it's actually pretty likely to be COVID. And yet people often say to me things like, oh, it's just flu. I'm like, it's not flu. There really isn't any flu around. And I think this idea that people think that it's not very likely to be COVID because they can still smell and taste, for instance, does mean that people then don't behave in the way that they might if they thought they did have COVID. So I think it definitely matters. How to change that? Well, you need better public information. I don't know how to make that happen, but I think that's what we need.
Yes, absolutely right, Christina. Couldn't agree more. Helen.
Sorry, just struggling to unmute myself. Yeah, I mean, it's a real problem. Lots of people really don't want to think they've got COVID, and we're kind of conspiring to help them believe they haven't got COVID. It's quite likely that these respiratory symptoms, they've got a runny nose, they've got a headache, they've got a bit of a fever. It may well be COVID, but it costs to get a test. So why would you test? If you do test positive, that's going to make you feel guilty about visiting other people and in the way of this. So it's a whole load of reasons we're pushing people not to find out whether they've got COVID or not. And to be honest, because it is completely out of the news. I mean, when did anyone last hear about the number of deaths each day from COVID? They're still happening, but it's not on the news. People are still in hospital with COVID. It's not on the news. A lot of people honestly have thought it's gone. And if you say if somebody rings me up and, they've got respiratory symptoms, I say, have you done a COVID test? It's kind of, oh, I hadn't thought of that. So it's really out of people's thoughts now, because I think the government has done a very, very effective job of convincing people that the pandemic is over. So yeah, it's a real problem. We need to possibly raise the profile again. Nobody wants to think about it, but we probably do need to raise the profile again. And we need to make testing more available so that people can know without it being a personal cost to themselves.
Absolutely right. Christina again, quickly.
Yeah, sorry, and I just wanted to ask Helen about this as well, because I think one of the first symptoms in elderly people can often be increased confusion, particularly if they already have some dementia. And I think that's just something to watch out for. And it's literally just happened to the parent of a friend of mine where, no one tested him for about 5 days. And then it turned out he had COVID and then passed it on to his vulnerable wife. And so just something to bear in mind. I don't know, Helen, if you want to add anything.
Yes, absolutely. Symptoms can be extremely non-specific, particularly in older people. Loss of appetite, which may be because they can't taste the food anymore, confusion, fatigue, sort of just generally going downhill without a really good reason. And it can take quite a long time to anyone think, oh, maybe you ought to do a COVID test. And when you do, it's positive.
Oh, and Steve Reicher?
Yeah, we just recently ran a series of experiments, and these were basically looking how quickly people report their symptoms and how quickly they are likely to get tests. And the factor that we found most important wasn't a sense of personal risk. it was the sense of social risk, of risk to the community. And that takes us back to something which Lara was saying, and I also think something that Helen was saying, that one of the main reasons in the past why people took action against COVID wasn't for themselves, it was for their community. It was out of social responsibility. And one of the other things I think we need to do, if we want people to take COVID seriously and to act on it and to test for it, is to make clear that the issue isn't just you, it is we. And what we've heard earlier in this session about the impact on vulnerable people is the more that people don't get tested, the more they create an environment in which vulnerable people feel they cannot go out into public. So I think we need to get away from personal responsibility, go back to social responsibility. And we do have a responsibility socially as well as to ourselves to find out whether we've got COVID and whether we are likely to impact on other people, especially those who are vulnerable.
That's great. Thanks ever so much, guys. And just to add, very small thing, remember symptoms are always a combination of the virus and our immune system, and that can also change with age. And I think, we also had a reminder of what just the flu was like just before Christmas. Not trivial, but thankfully only one wave per year. Anyway, I shall move on to the next question, which is for me to read out, which is from Will Newcomb. And he's saying that with the news that the Johns Hopkins University is closing its COVID tracker function, where do we go now for reliable information? Does Worldometer or our World in Data have other reliable sources? So that's probably one for our maths experts. Kit?
Yeah, it's a really interesting point. I think we have to continue to look at a wide variety of data, because I don't think one, as you've seen in the presentation today, I don't think any one data source can really indicate exactly what's going on. ONS is probably our gold standard in terms of infections, but it's so lagged that we may already be decreasing, and ONS has only just picked up the most recent increases. We need to. Hospitals have actually become one of the leading indicators now that we're not testing very much. It used to be that when everyone were tests were free and tests were available, then we would pick up rises in incidents very quickly. But now, strangely, hospitalizations used to be a lagged indicator, but are now probably our leading indicator, along with Zoe. So I think we always have tried to combine multiple data sources to get a full picture of what's going on. The number of those data sources is diminishing, unfortunately, so we're not getting as clear a picture. But fortunately, the ONS infection survey is continuing, although it's at a reduced size. There's talk about doing away with it, which would be a real shame. In fact, if anything, we need to be taking the model that we've used for the ONS infection survey and replicating it for other diseases. I think we should be expanding our surveillance and learning lessons from what we did with COVID. We scaled up. We spent loads of money doing COVID testing and putting in these data structures and finding out what's happening with variants. And then it's almost as if we've decided we don't want to think about COVID anymore, so we're just going to forget all that learning. And I think that's a real shame. But yeah, I think overall the answer is to use multiple data sources and try and not just rely on one data source too much.
Thanks so much, Kit. Anyone, any other thoughts on that, or should we move on to what's probably going to be our last question? Okay, I'm going to skip one from an anonymous provider because it's quite long, and move on to one given to us by Susanna Thacker. And she's asking, have there been any studies on the clinical significance of individuals testing positive on an LFT or other tests for more than 14 days, particularly on whether or not they're likely to be infectious still? Also, is there any indication of adverse outcomes in healthy people testing positive on LFTs for extended periods? So that's an interesting one for our immunologists, I expect, or clinicians.
Explain LFTs. Do you mean liver function tests or lateral flow?
Sorry, lateral flow tests, Anthony.
Oh, right. Okay.
I mean, I could maybe kick off then, because there are some studies that show quite unequivocally that being positive on a lateral flow test, that amount of viral, parts of the virus you're detecting literally in those tests, that does correlate very well with infectiousness, particularly as you're coming out the other side of your most symptomatic period. So yes, you are probably infectious if you're positive on a lateral flow test. Danny, did you?
Yeah, no, I was just going to be in charge of stating the obvious, that yes, that longer lateral flow test positive equals infectious for longer equals higher viral load on board, tends to equal higher immune response induced. And that's about as far as I'd go. I'm not sure if there's any sort of further implications for, being sicker or being sicker for longer or more long COVID, but certainly more virus on board and more immunity induced, and still infectious, yes.
Okay, great, thank you. Sheena, did you have anything to add there? No? Okay, guys, well, I think I'd probably better bring it to a close there, as it's just gone 1/2 the hour. Thank you, everybody. That's all the time we have, sadly, but thanks to our guests for joining us today, to Steve and to Janet for hosting, two excellent guests, Lara and James, really insightful experiences. I think we all need to remember the plight of our clinically vulnerable people, particularly in light of recent announcements of medical provision. And of course, thank you as always to the members of our public for their questions, and of course your continued support from our crowdfunder and other ways. And we'll be back in 2 weeks' time. Please remember, we're bi-weekly now, same time, same place. So until then, please stay safe, everybody, and look after each other. See you soon.
Bye.